Dear audience, it is with a great pleasure that I may introduce today the first educational webinar in a new series, Ground Rounds in Breast Cancer, produced in collaboration with ecancer and a lot of leading partners. The webinars will take place 4 times a year and will promote peer-to-peer discussions of high-value breast cancer care within resource-limited settings for healthcare professionals around the world. The aim is to discuss controversies, real-life challenges, and effective application of existing knowledge. Today, I have the honor to introduce to you Professor Pankaj Roy, who will be the presenter of our first webinar about quality management in breast surgery from breast conservation to breast reconstruction. Professor Roy is Senior Consultant Oncoplastic Breast Surgeon at Oxford University Hospitals and Associate Professor of Breast Surgery at the University of Oxford in the UK. She has been instrumental in setting up a high-quality oncoplastic service at Oxford since her appointment in 2011. After her presentation, Professor Terry Sarantou will be discussing. Professor Sarantou is a surgical oncologist with extensive experience in breast cancer working in Charlotte, North Carolina in the US. He's past chair and active as site reviewer of the National Accreditation Program for Breast Centers and has special interest in cancer care quality, standards, and education. When you have questions, please put them in the chat during the presentation. Pankaj, please give your presentation.
Thank you, Professor Verhoeven, for the kind introduction, and thank you to Professor Sarantou for discussing the topic after my talk. It's indeed an honor to actually open this webinars on the value-based healthcare on breast cancer. So quality management in breast cancer surgery from breast conservation to breast reconstruction. So I'm going to discuss this topic first looking at the definition, the benefits of oncoplastic breast conservation surgery and what is the evidence with regards to outcomes, talking about mastectomy with or without reconstruction, then auxiliary surgery and the de-escalation associated with it, what are the disparities and how we put the available evidence and the key driving factors into perspective for low resource countries, and then where do we drive this into key focus and messages, and also talk a little bit about training. So oncoplastic breast surgery is defined as undertaking cancer resection, but combining it with techniques which are popularly known with plastic surgery in order to improve the outcomes for the patient, to improve the aesthetic outcomes. And this has been published in 2012 first under the auspices of Association of Breast Surgeons and British Association of Plastic Surgeons, and now the 2021 updated guide has been published in the European Journal of Surgical Oncology. So what does it include? Include all aspects of breast cancer surgery, starting from simple, what we call as a wide local excision or breast conserving surgery, also known as level 1 techniques, where smaller volume of the breast tissue is excised in order to ensure complete resection, and mobilizing the surrounding tissue so as to obliterate the dead space, because it's a combination of dead space followed by radiotherapy, which results in dimpling or divoting or poor aesthetic outcomes. And then when the volume resections are larger, you can use oncoplastic breast conservation techniques, which can be therapeutic mammoplasty, which is a volume replacement, or something similar to breast reduction or mastectomy, or volume replacement technique, where the excised volume is replaced with a flap tissue. And the common ones, which are currently, is the chest wall perforator flaps. And these techniques are usually for resections greater than 20% of the breast volume. And then comes patients needing mastectomy, that we combine them with total breast reconstruction where appropriate, using implants or autologous breast tissue, and then also assess the patient for any asymmetry that has developed as an impact of the treatment, and consider symmetrization surgery where appropriate. Now, how does oncoplastic breast conserving surgery compares with the standard? Standard breast conserving or level 1 techniques still remain applicable in vast majority of the patients, particularly in the high income group, where countries where there is a huge amount of patient understanding, early presentation with smaller cancers, and the screening program, which detects impalpable cancers. However, oncoplastic techniques provide opportunity for better cosmesis for tumors which are bigger or relatively bigger for the patient. So it's not about the absolute tumor size, it's a tumor size to breast size ratio. In women, a smaller tumor in a very small breast could be a difficult one to give an optimal aesthetic outcome with a simple wide local excision. Or tumors which are associated with extensive DCIS, although they're prognostically and treatment-wise, they remain very good outlook, but extensive DCIS associated with these cancers means larger resections. And similarly, if tumors are present in a cosmetically sensitive quadrant, such as upper inner quadrant. These techniques also provide an opportunity to avoid mastectomy in some of these patients, and it also helps to preserve the anatomy and sensation in the unaffected part, thus improving the quality of life with psychosocial benefit and productivity. These techniques are often relatively quicker surgery compared to total mastectomy and whole breast reconstruction, with shorter hospital stay, which is very importantly translate into financial viability of these procedures. And in the current climate, I think the resource in an issue, global issue, rather than limited to low resource countries. And therefore it is our responsibility to make our treatment options as financially viable and sustainable as possible. Now, these are some of the examples. So on the right side is a large-breasted woman who had a 4-centimeter cancer in the lower quadrant of left breast. So she had therapeutic mammoplasty on left and a symmetrization breast reduction on the right. So not only you've given her something positive as a part of a very sort of negative breast cancer journey, but also this has a benefit for the radiotherapy colleagues because it's much easier to provide homogeneous distribution of the radiation in a smaller breast as opposed to larger breast, whereby radiotherapy results in quite painful breasts afterwards if the breasts are large. And then you have this patient who had a 5-centimeter cancer in the outer quadrant with extensive calcification. So she had a relatively simple, straightforward racket handle mammoplasty with excision of the tumor and a good aesthetic outcome. And she may or may not need or want to have contralateral breast reduction, something we can assess later on where the excision is not that big, or it could be that her breast on the right side was smaller before, and now you've reversed the asymmetry, and she may be happy to live that degree of asymmetry. So this is some examples of volume replacement or partial breast reconstruction. On the top left is a lady in her early 50s with a grade 3 invasive lobular cancer, which was 45 millimeter node positive. So she has neoadjuvant chemotherapy with good response and then presents to me for surgery. And I think what is absolutely important to think about is in a node positive grade 3 cancer of that size, she will be offered radiotherapy irrespective of breast conserving surgery or mastectomy. So mastectomy is not going to save her from radiotherapy. So she was offered partial breast reconstruction and had volume replacement, and that's her 4 years later. I don't think any other form of surgery can provide her that kind of quality of life and maintain symmetry and a positive psychological impact. And the lower picture is a very, very slim lady with small breasts, and she had DCIS in lower outer quadrant, which was about 5 centimeter. She is a challenge to any surgeon with regards to reconstruction options. If she does not have autologous tissue, and if she was to go for implant-based reconstruction, you're looking at bilateral surgery. So this lady actually had 2-stage approach to partial breast reconstruction. This is actually her post-op picture, which is on the lateral aspect, looks like this. I don't think any other surgery can give her the outcome with quick recovery and minimal disruption to her quality of life. And this picture on the right is a lady who had a mammoplasty for a 4-centimeter cancer, which was grade 3, and she required chemotherapy, but her tumor was associated with DCIS, which was a positive margin on the nipple side. So therefore she required further resection of the nipple. She was offered mastectomy with free flap, and she thought about it very carefully and said, I would like to avoid that because I look after a disabled member of the family and do not have 3 months to recover from a big procedure. So she had partial breast reconstruction after mammoplasty with replacement of the nipple areolar complex excised skin with the skin from the flap. And that's where you can push the boundaries once you start doing these techniques. So what is the evidence with regards to outcomes? So we've published the Cochrane review on oncoplastic breast-conserving surgery. The level 1 evidence is still lacking because it's quite difficult to carry out randomized controlled trials, although there are efforts going on globally for that to get the evidence, but there are individual series with a relatively long-term data between 5 to 10 years, which suggests these techniques are safe. However, we need more comparable data to actually provide the evidence. So this is a small effort on our team to look at retrospectively on the data of patients undergoing surgery at the same time period. So 80 patients undergoing breast-conserving surgery versus 40 undergoing partial breast replacements were compared over a 7-year follow-up. Despite bigger tumors being treated with oncoplastic breast, which is the first column, we had lower need for resection, as in excision of margins or mastectomy, as compared to patients undergoing standard breast-conserving techniques. And this was statistically significant. And similarly, over a period of 5 to 7 year follow-up, more patients required contralateral breast symmetrization surgery with standard techniques because of the shrinkage with time and excision of the tumors. And that's where I would say the need for second operation to clear the margins, contralateral breast surgery, is probably underreported, and it has a significant financial and psychological burden to the patient, to the hospitals, to healthcare, and to the society. This is our series of 100 partial breast reconstruction cases with 8-year follow-ups, and our local recurrence rate was 2%, which is the aspiration as per the Association of Breast Surgeons to keep the local recurrence rate below 5% at 10 years. So I think the data speaks for itself in terms of safety, although there is acknowledgement that the level 1 evidence is still lacking. Simple mastectomy, this is my favorite topic. Is it really that simple? This is often considered as a simple surgical procedure, often left towards the end of the day in terms of planning, not uncommonly left to the junior member of the team, because breast has also been viewed as a dispensable organ and often offered to patients with regards to when you're talking about the choice and patient decision making. And I will contest that this is not simple, because there's a higher risk of post-op complications such as seroma, wound breakdown, or aesthetic appearance of scars compared to breast-conserving surgery. And the psychological issues are often underreported and underestimated in these women undergoing simple mastectomy. And we do not forget that there is an ongoing cost, both financial and psychological cost, to these patients living day-to-day life as a constant reminder and how difficult it is in terms of clothing, in terms of confidence, in terms of carrying out day-to-day activities. And of course, the post-mastectomy pain syndrome, which I'm not sure we paid due attention that it deserves. And then there's a publication from China which has suggested that the surgical cost to the hospital is higher for a mastectomy without reconstruction as opposed to breast-conserving surgery. So let's look at the evolution of mastectomy. This is the Halsted mastectomy, which was involves removal of the pectoralis muscle with breast and along with all the lymph nodes, which was mutilating, so to speak, but that was the treatment available in those times. In fact, there is a paper published by Veronese in 2012, which looked at the evidence of outcomes, survival and local recurrence outcomes, 20-year follow-up comparing mastectomies radical mastectomy with breast conservation surgery after introduction of Bernard Fisher's breast conserving technique. And the local recurrence was 9% at 20 years after breast conserving and 2% after radical mastectomy, but there was no survival advantage. I think I would accept some recurrence local rather than go for this surgery. I think that's probably has been proven. I don't have to labor that anymore. And then came the pectoralis muscle sparing mastectomy, but with less attention to the scars, to the dog ears, to the contour of the chest wall. And that was followed by oncoplastic mastectomy, where you want to make sure that the patient's chest wall is as flat, scar as low and less visible, so that the hygiene is easy to maintain and she can wear her prosthesis comfortably. And any reconstruction taken on later on provides the best outcomes. But still, there are avoidable but not uncommon outcomes. I would say it should not say uncommon, it should say common outcomes. So these things we see in daily lives, and this is basically poor planning. To say this is patient after mastectomy, I don't think is right in my view, because taking away the dog ears, making sure we provide a clean, neat scar is very much part of surgical planning. And similarly, this is technical disaster. And then these outcomes, I don't think it lies within our control. This is a patient who had mastectomy and axillary node clearance, followed by multiple seromas, required radiotherapy, developed local lymphedema. I think these outcomes are very difficult to manage and to control or to avoid. Whereas if patient had breast conserving surgery, if that was possible and feasible, she could have avoided this kind of outcomes. So now let's look at what the evidence suggests. Is mastectomy better than breast conserving surgery? So does mastectomy save lives? So this is the paper I earlier quoted from Veronese, comparing radical mastectomy with breast conserving surgery, which showed no survival outcome, but slightly higher local recurrence rates. I mean, this was from 1973. And that's the paper from Swedish registry about looking at breast conserving surgery with mastectomy, and the survival rate difference was better in the breast conserving surgery, whereas the local recurrence was 10% at 13 years with breast conserving, 5% with mastectomy. And this one shows better survival with breast conserving, lower distant recurrence rates with breast conserving surgery in triple negative breast cancer, and yet another paper. So I think the jury is out. It does not save lives. Does it prevent local recurrence? This is another Swedish registry paper which looked at patients having breast conserving surgery between 2010 to 2016 at 5-year recurrence rates, and it was 2%, which is, I think, very acceptable and is the aspiration, what is now quoted by Association of Breast Surgeons in the UK, to keep the breast conserving surgery recurrence, local recurrence less than 5% at 10 years. So I think driving down these local recurrence rate is a tribute to better radiology techniques where we can look at, we can diagnose our cancers more accurately, better pathology when we send those samples, big samples, to our pathologist colleagues who look at it painfully and make sure we've got clear margins. And then, of course, a huge, huge improvement in the various drugs and treatments, including radiotherapy, which drives the local recurrence outcomes into a better phase. So not really, in my view, it doesn't really prevent recurrence, only caveat in patients who are gene mutation carriers or very high risk family history, where there is a risk of second cancer rather than recurrence. Does it improve psychosocial outcomes? I don't think we need to labor that point. There is plenty of data which suggests that's not the case. So does it reduce the fear of cancer recurrence? Unfortunately, yes, because we see it day in, day out, patients asking for mastectomies. Who is to blame? I would say you and me. You can disagree, but that's what I would contest. That's the case. And that's where we are seeing a rising incidence of patients requesting mastectomies and bilateral mastectomies, although there is a huge geographical variation, but still patients are asking for it, and it's usually out of anxiety and fear. And it is absolutely paramount that a good time is spent on counseling and explaining the difference so that an informed decision is made in the clinics. And patients undergoing one-side mastectomy, there are some patients who would offer, who would request for bilateral surgery. Why is that? Some bit is because of worry, some bit is because of family history, which may be misunderstood rather than a true risk, or for symmetry, because you're having implant-based reconstruction and therefore going to end up unequal, or having an abdominal reconstruction, so might as well have both sides reconstructed. I think it is important that the impact on their recovery, the timing of surgery, and the resource implications is crucial. In fact, in the UK, it is now expected that patients who are not a high-risk family history, if they ask for bilateral, they have to be assessed by 2 different clinicians and a psychologist before they're offered bilateral surgery. And I would also say that if we were to adopt oncoplastic breast-conserving techniques where mastectomy could be avoided, we could actually drive the whole thing in a completely different direction, which will be favorable and sustainable. Then mastectomy with immediate reconstruction. I think it's a great outcomes in good hands, but not without its cost, because look at this patient who has got a fantastic result from a latissimus dorsi autologous flap on the right side, followed by nipple reconstruction and tattoo. And this is a delayed reconstruction with abdominal free flap. But these things take time in theaters. There is a recovery period in the hospital, followed by convalescence at home. So there is an impact on patient life, patient productivity, patient family, hospital costs. And of course, there is a variation in availability, particularly the microsurgical expertise is not routinely and widely available, even in the high income countries. And then we have to think about morbidity, time to recovery. And then this is another patient with implant-based reconstruction. There is cost involved with the ADM use that's currently in vogue. However, asymmetry still can be an issue after these reconstructions, similar to breast-conserving surgery. So whilst these techniques are absolutely important to master and for patients to be available, we have to make sure that the mastectomy rates are not unnecessarily driven in the direction of a higher rate. So what's changed over the last decade, I would say? There is an evidence on safety of breast-conserving surgery over mastectomy. So we've talked about that. There is an aspiration and efforts going worldwide for better training and adoption of oncoplastic breast-conserving techniques. And we have evidence on improved aesthetic outcome and emerging evidence on safety of these techniques, although not level 1, but there still remains wide variations in mastectomy rates globally, more so in low resource countries. There are training gaps, which are widely acknowledged, and there's a massive disparity along the availability of treatment in general across the globe. So what needs to happen? Of course, there needs to be more training efforts. How do we do it? That's what I think this program, the webinar program, will hopefully acknowledge and address at some point. Patient education, clinician education, and patient education should involve increase awareness in low resource country, and I'll come to that in the next slide. And of course, we need easily available, or at least widely available, radiotherapy facilitates if we were to drive oncoplastic breast-conserving surgery. And that also requires policy making to make sure that we are incorporating clinically effective surgical measures to ensure there is sustainability in what we offer and provide to our patients, in addition to driving the improved cosmetic outcomes. Let's look at the disparities and put into context the talk I've done so far for low-middle countries. So we know the incidence is higher in high-income countries, but that also is evidence of there's a availability of screening programs in those countries, which means early detection, which is not the case in low-middle income countries. And because of the bigger populations, the numbers are not necessarily widely smaller in the low-middle income countries. And then the diagnostic issues, early versus late diagnosis, which often is the literacy, education, financial disparities, or access to treatments, and then the training issues. So this is a systematic review about delays and barriers to cancer care in low-middle income countries. And then there is a paper which is talking about how can we bridge the training gap for breast-conserving technique oncoplastic procedures in those areas. So if you look at the stats from the IARC from 2020, 2.26 million new cases of breast cancer have been diagnosed worldwide, and about 700,000 deaths. 2/3 of those deaths are in low developed area. And this mortality difference is markedly driven by inequality due to variation in diagnostic and treatment facilities. And I would add to that, mainly the presentation is delayed. And we'll talk about that in the next slide. And this 80% survival at 5 years in developed, as opposed to less than 50% in South Africa, I think talks about the inequality. The data speaks very, very loudly and calls for efforts. And that's exactly what is being done in the WHO initiative. Now, the systematic review has looked at the barriers to cancer care, and lots of aspects have been looked into, including health literacy, cancer stigma, cultural issues, access, inaccurate diagnosis or limitation in diagnostic facilities and financial constraints. To some extent, all of them are responsible. But what comes out is delayed presentation as the main barrier. More than 50% of these cancers are delayed presentation. And health literacy was the most commonly reported barrier. However, it was acknowledged in the review that the data is based on what is published, and a lot of information is probably not in the published zone. And this is the table which tells us that it is a late presentation, 6 months from noticing a problem in the breast to actually presenting to a physician was the main thing. Once they reach the clinician, then the diagnosis and treatment is not necessarily significantly different between low income, middle income, high income countries. It was mainly it is a presentation. And that's where the focus needs to be on, is narrowing the gap from symptom to presentation, which is what WHO Global Breast Cancer Initiative is focusing on, about the health literacy. And of course, and that's what I was wanting to bring out, is the key focus on the primary issue remains access to facilities, comprehensive treatment, that remains on the top, but we can also drive other things simultaneously to actually improve patient outcomes, to help the wider society and narrow the time to actually take on multiple steps to reach where we want to reach ultimately on a global platform. Because we know early diagnosis will improve survival and reduce cost of treatment. But I would argue that there is a greater need for oncoplastic breast-conserving surgery training and techniques in low middle income countries, because the presentation is quite varied geographically within those countries. And these patients would benefit more from some of these techniques. And although you may not be able to carry them out in some of these patients, or it not be feasible to do that, but I think there is a place for these techniques, for training the surgeons to actually empowering the clinicians to be able to do that where feasible. And then, of course, there's a role of neoadjuvant chemotherapy, particularly in triple negative and HER2 positive cancers, where the breast conservation rates can be increased by the introduction of techniques. So it's going to be a multi-pronged attack to tackle at a global platform to provide the right treatment to patients. There remains challenges for adoption of these techniques in low middle income countries. I'm not saying it's straightforward, it's easy, because you also need to couple that with high quality radiology detection platform and pathology resource to be able to scrutinize those samples for adequate resection of the tumors. So I will be doing, I will not be doing the favor to the talk if I don't talk about axilla, because axillary node clearance for a clinically node negative axilla is a thing of the past, in my view. 20 years ago, 30 years ago, that was a standard of care. But now sentinel lymph node biopsy is the standard. I don't think we can justify the morbidity of clearance with lymphedema and pain to the patients where there is no node spread. And I appreciate there are challenges with regards to equipment, training, and education, but there are simple, easily available, easily trainable alternatives like blue dye node sampling, or the new techniques, magnetic techniques that are available, which can circumvent some of the challenges with radioactive material. So what are the take-home messages? Adoption of these techniques, oncoplastic breast conserving, to widen the indications and reduce the likelihood of further surgery. Avoiding mastectomy when safe and feasible. It's important that the patients and clinicians are educated about the non-superiority of mastectomy over breast conserving surgery. We ensure shared decision-making by educating the patient. Patients asking for mastectomy out of fear and anxiety is not a choice. Pre-op imaging and marking of the tumors is crucial when undertaking resection for oncoplastic, and therefore importance of adequate radiology and pathology facilities, along with dedicated tumor boards or a multidisciplinary team meetings. Then assess for availability of radiotherapy facilities when committing a patient to oncoplastic breast conserving techniques. I'm very mindful that sometimes patients may have to travel long distances to be able to do that. And standard breast conserving technique or simple breast-wide local excision still remains the procedure of choice for small impactable cancers where feasible. It is important, whilst we're doing all things, we don't lose perspective. One size doesn't fit all. We have to make sure it works for the community, to people who are working and actually being treated in that particular scenario. And every country may have a slightly different solution for their population. There are worldwide training efforts happening, such as Association of Breast Surgery International Forum, oncoplastic fellowships across the world, from US, from UK, Europe. There are lots of fellowships happening, which provides the hands-on training. There are webinars and conferences and patient support groups to educate and also keep people up to date. And then I think our book will have the statements for setting the standards to make sure it is a guide for people undertaking and performing and policymakers, but a big caution for all the surgeons. Certification and hands-on training is essential. Attending webinars does not provide training. It helps us to network, to build on experience, to mentor each other, but the training is absolutely crucial. Thank you. And then the final slide, breast and axillary conservation surgery is the sustainable future. And that's globally, worldwide, because it's oncologically, as long as it's oncologically safe, because it is quicker recovery and provide improved psychosocial outcomes, which translates into society and productivity. It's financially viable for the health service. And of course, we have to also factor in the climate impact. Shorter procedures, lesser hospital stay, all has positive climate impact. And the caveat remains about the radiotherapy facilities, and which is also something we need to factor in to focus on low cost on mobile radiotherapy facilities in partnership with charitable sectors to be available where it's not feasible.
Didier, thank you for asking me to participate today. It's my pleasure. And Dr. Roy, I compliment you on an excellent presentation. Certainly, Dr. Roy, you've shown us that the use of oncoplastic surgical techniques are and will continue to play an important role to enhance oncologic and cosmetic outcomes for our patients. You have outlined the optimal techniques for volume displacement and replacement, with enhancing opportunities for patients to undergo breast conservation surgery, as well as highlighted the importance of symmetry in breast surgery. I think all too often we have not really paid as much attention to symmetry, and thank you for outlining that, the importance of that. You also touched upon implant-based reconstruction and the evolving field of autologous tissue transfer, but we know even in the US, where resources are more available, perhaps there's still challenges in undergoing these types of procedures. We certainly have come a long way in offering oncologically safe and aesthetically improved opportunities for women to undergo breast and chest wall reconstruction, as you've highlighted in the photographs that you showed. Oncoplastic breast surgery provides opportunities for improved cosmesis, but we also must not forget to realize that our patients' fears and expectations through their cancer journey, and constantly remind ourselves as physicians that we should be developing treatments that reflects their care also as they experience, while providing them, as you outlined very importantly and nicely, to educate our patients. Thankfully, breast conservation is accepted globally as optimal care for many women with breast cancer, but as you discussed, there are disparities and barriers to care that exist worldwide of offering breast conservation surgery that we must continue to work together to discuss. Training in oncoplastic techniques needs to be expanded globally, with also enhanced patient education regarding the safety and quality of oncoplastics. And I think we can do a better job working on the training aspect of it. We've done a very good job about that. And I also think that we must also pay more attention to educating our patients, as you outlined. Time to treatment delays and barriers to care are increasing globally due to many factors, and we must address these delays with very thoughtful solutions. The meaningful use of data and quality metrics with multidisciplinary input should be constantly reviewed to address the barriers and disparities in care. As we know, breast cancer is a global problem, but it certainly can require a global and not a regional solution. Although, as you discussed, we must be thoughtful of disparities that exist in individual areas. I think we can do a better job of identifying which data is important, and we also need to do a better job of sharing that data. Data is very powerful, and it can also lead to thoughtful accreditation or standards that can be practical for physicians and patients to understand the optimal care. Enhancing treatment in low and middle income countries must occur with presentations such as yours, Dr. Roy, and this brings the issue of global barriers to care at the forefront of discussion. Although breast conservation surgery has become standard through much of the world, we must also address the barriers to women obtaining breast conservation, as well as the continued upward trend of patients either requesting a unilateral or bilateral mastectomy. And as you outlined, there can be significantly increased risk for patients with morbidity with these more aggressive surgical techniques. And there's not been, as you said, any improvement in overall survival. Thankfully, we are de-escalating axillary surgery. I tell our fellows and residents that we are some of the now original minimally invasive surgeons that were performing sentinel lymph node procedures. And with the improvement of systemic therapy and offering of radiation therapy, as you discussed, very few patients in the future now will require an axillary clearance. And this certainly will help decreasing the morbidity of lymphedema. You touched upon that we must continue to reinforce breast cancer diagnosis through screening. Again, as I've traveled throughout the world and certified breast centers, this is a real important problem that we must address, enhancing screening techniques. And we must continue to reinforce diagnosing breast cancer, decreasing time to treatment delays in the diagnosis of breast cancer treatment, and enhance the use of systemic therapies, such for triple negative cancers and HER2 overexpressed cancers, and then also incorporate radiation therapy, which can be difficult in some areas of the country, of the world, excuse me. We must continue to enhance physician and staff training regarding advanced surgical techniques in breast surgery and patient education. Surgical innovation is important, but again, as you outlined, there must be a mechanism of training, of certification, accreditation, and recognition. So we really ultimately must need to remember to look at our treatments through the lens of our patients. Thank you very much.
Terry, do you have now a question to Pankaj, or must I start with some question of Helena Earle?
I have a question. Yes, I do. I'm very interested again in standards and accreditation. Please, I know you touched upon this in your presentation, and thank you for doing that. I'd just like you to elaborate a little bit more in terms of what you feel, how we can start the training for surgeons worldwide. Can we teach surgeons to do a level 1 displacement procedure without significant certification? And then how do we move forward with, say, the more advanced oncoplastic procedures and techniques in terms of certification or accreditation? I know that a course is not adequate, but how do we address some of these barriers that some surgeons will have to obtaining the additional training that's required?
Thank you, Professor Sarantou, for a very nice roundup. I think certification of surgeons has been a challenge always, and how do you ensure uniformity across any hospital, let alone globally? But I think with breast surgery, given that there is a increasing recognition of it as a standalone specialty across majority of the countries, there is an increased opportunities for people to practice and undertake procedures which are as in straightforward procedures for breast cancer, and therefore training for level 1 oncoplastic procedures, I would think, would have lesser challenges, because that would require a shorter time period to train. And whether that involves people coming and working in centers for a month or a couple of months, depending on their level of exposure in the past. And this requires a careful thinking and planning, so that there is some sort of agreed standards minimum data set for each individual, and that would depend on the logbooks, their exposure, their experience, and what kind of support network they work in. Do they work in a multidisciplinary team meeting support, or do they work in isolation? Do they have other surgical members to support them? Do they have plastics teams to support them? So I think it is not something which we can resolve today on this meeting, but absolutely, I think we need to cover that sort of minimum data set on a global platform. And going on to the level 2, that remains a bigger challenge to achieve, because you require much longer period of formal training with an accredited center with at least multiple clinicians, so that you get to see enough numbers in that period and participate directly before you can be signed off as accredited for training. Thank you. I'm not sure if I answered the question adequately.
No, of course, yeah. I'm currently serving on the board of directors of the American Society of Breast Surgeons, and a very important topic for our board has been this question of how do we move forward with oncoplastic certification, as well as partnering with our reconstructive communities. So we have been discussing this for a year, and we continue to discuss it. There is not an easy solution, as you've outlined very nicely, but I'm certainly glad that we are moving in this direction, and there's careful thought behind it. At times in the past with surgical innovation, there has not been as much careful thought, and I'm very pleased that there is careful thought with this. And it's such an important advance where we can really change the care that we offer patients, because although mastectomy is increasing in trend, as you said, many patients have many postoperative issues that are lifelong afterwards, and there are challenges with that. Thank you.
Then perhaps a question from Helena Earle from Cambridge. How will you facilitate translation of evidence into effective policy-making decision? Not so easy, but nevertheless.
I didn't expect an easy question from Helena anyway. Thank you for that, Didier. I think that's where your book, Didier, would come as the key player, because we need clinicians across the world to actually put their head together to provide a minimum data set, as we said, about the evidence projecting into what is it required to expect an oncoplastic unit to perform. And that's where we need to, I think that the collaborative effort to create a minimum data set, which is the minimum standard to expect, and that would guide the world policymakers to address. And hopefully with the second edition coming with the updated edition and being available on a online platform free of cost, would make it more easily available and endorsed by a wider community.
Perhaps a question from myself about reconstruction as a non-surgeon. How you choose between simple prosthesis, more quick and cheap, I think, deep flap, drum flap, and other kind of reconstruction. What are your ideas about?
Absolutely. I think these are the conversations which I find myself sometimes quite challenging, even though I've been practicing for some time now with the patient, because it all depends on expectation of the patient, what is feasible for that patient, what are the comorbidities of the patient, and what is the disease, how quickly the disease requires treatment, and therefore how much time patient can have to think about the treatment? Can we facilitate neoadjuvant therapy so that patient gets a little bit more time to spend on their treatment options in terms of surgery? And we are very fortunate where we are to have a very good plastic surgery colleagues, so patients tends to see different members of the team to look at the aspect. They meet with a breast care nurse. So between us, between 2 to 3 people, clinical team, understand patients' perspectives, patient expectations, and also make sure that the patient is given the realistic expectations in terms of what can be achieved on them safely. I think these are the conversations where you require a multidisciplinary approach to this. Of course, patient remains in the center, and it's important that we empower them with the information and adequate time to provide them the opportunity to make the informed choice.
And can you say in general, you are more in favor of a deep flap, or that's not a good question?
That is actually a good question, but that is exactly how patients sometimes will see, well, what do you think is better? It's not, there's no global answer. What is better for that particular patient sat in front of you? There may be a patient who's completely slim and think that he's got a big tummy to have a deep flap. They can't have it. Similarly, a patient who has other comorbidities where a 12-hour or 6-hour or 7-hour operation is not a good idea. And similarly, a patient who's on steroids, I wouldn't want to do an implant reconstruction on them. So there are lots of factors to take, and nothing is good for everyone. And similarly, one particular technique may not be good for that patient. Patient may have a choice for different techniques.
How would we assess that information in terms of how, is it a patient satisfaction survey, a registry trial? How do we, I don't see as much about that in the sense of, you know, the patient satisfaction with the procedures that they've had. Mm-hmm.
So that's a very good question. So I think there are 2 aspects of this. One is patient advocacy. Do they have enough time and information to make the choice for themselves? And then looking at their journey, what kind of complications and what kind of experience they had at the time of treatment, and then assessing them probably a year or 2 years later to say, how do they feel satisfied or not satisfied with the outcome or the reconstruction. And these things are quite difficult to actually measure on a multi-center or a multiple data set, but these are the best we can get. I think you have to look at multiple aspects here. There is one of the Italian surgeons who's working on patient advocacy to help patient make that informed choice. I think that's the key, in my view, to start off, that they are able to participate in that conversation and make the choice which they can themselves. Because if they are able to make a choice which they own up to the choice, then they're more likely to be satisfied later on. And similarly, looking at their experience through the journey of perioperative care with regards to complications is another aspect which I think is absolutely crucial.
Then a question from Hans Junkermann from Germany. What do you think about the impact of endoscopic and robotic surgery techniques in breast surgery? Was put in the chat.
Yeah, thank you, Hans. I expected that from you. My exposure to endoscopic and robotic surgery in breast particularly is very, very limited. So I haven't made a viewpoint yet, but I know the people who've done some of these techniques, particularly the endoscopic in the Far East, who've come out with excellent results. I think I have to say I'm not the person to make a comment, given that my exposure is so limited, that I'm probably not the right person on that.
And another question from Belgium. Are the trends towards neoadjuvant systemic therapy an effect on the visual outcome complication of breast-conserving surgery? It was put in the chats.
If I understood the question correctly, what the person is trying to ask is, does neoadjuvant chemotherapy or systemic therapy result in more complications with breast-conserving surgery? Is that correct?
No, it was, does the trend towards neoadjuvant systemic therapy have an effect on the visual outcomes complication of breast-conserving surgery? Oncoplastic breast-conserving surgery.
So there is increasing trend to use neoadjuvant chemotherapy, particularly for triple-negative and HER2-positive breast cancer, less so for estrogen receptor-positive cancers. And that is actually increasing the breast conserving rates, but it has no impact on the outcome in terms of complications or increased risk of complications with the patient, provided there is an adequate time between the last cycle of chemotherapy and the surgery to ensure there's a full recovery of the white cell counts.
Certainly, we're de-escalating radiation therapy, but despite the de-escalation with shorter times required, do you still view this as a real problem for breast conservation surgery worldwide? Is this really an issue of resources and access for patients?
Sorry, Terry, could you repeat the question? I'm sorry.
So thankfully we're de-escalating radiation therapy in shorter times for treatment, but this probably still is a problem in terms of resources worldwide for those seeking to undergo breast conservation surgery.
So we are reducing the time, the radiotherapy exposure time, but in terms of breast conserving surgery, we are not seeing any issue because the centers which are fully oncoplastic, they're fully resourced to that, apart from the issues created by the pandemic. But how that is affecting areas in the other countries, it's difficult to say. There was a period where a radiotherapy resource became quite a significant issue, but the 5-day radiotherapy or the shorter cycle helped to clear the backlog. What is the long-term impact of the shortened course of radiotherapy on the aesthetics? Time will tell us, because I think the paper was very promising, but long-term follow-up is still to come out.
Perhaps some other question of Helena Earle from Cambridge. How do digital technologies help with global training? Perhaps you have already asked, but I do it again.
Not at all. I think the digital formats and webinars and remote sessions are absolutely made a huge impact in informing people what's out there, in giving them opportunity to interact and network with clinicians and surgeons worldwide, and also to mentorship. I think this is a crucial way of mentoring people and helping to understand each other better and each other's, because we are working in very different patient demographics, very different patient profiles, and it's important that we keep that in communication channels open. But in terms of training, the hands-on training, surgical training, I think that remains a challenge to circumvent, because I don't think anything can really surpass the hands-on training. But there are, with robotic surgeries and things, that can potentially be a solution in future, as is happening with robotic surgery in other fields. But with breast surgery, I think we're still very much open surgery and hands-on, which requires physical presence.
And perhaps some last questions, or Terry had perhaps. But I want to ask you, do you find problems with direct reconstruction in high-risk breast cancer, or doesn't it matter? I'm not speaking about mastitis carcinomatosa.
Sorry, if I understood correctly, when I say high risk, not the family high risk.
No, not the family, but with a big tumor with 3-4 positive lymph nodes.
Yes, I think reconstruction still remains an option if it is not an inflammatory breast cancer and is resectable clinically with skin preservation. But if it is not, then we would not compromise the oncological side of things. Having said that, neoadjuvant chemotherapy or neoadjuvant systemic therapy, whether it's immunotherapy, chemotherapy, that has made a huge difference to how we now approach our patients. And that has actually opened up several different opportunities for patients.
I have a question. Do you think that there's enough worldwide acceptance of the sentinel lymph node technique, or are there still barriers to that among surgeons, as well as Didier? We can ask for his input through medical oncology as well as radiation therapy. At times at multidisciplinary conference, there seems to be some competing priorities in terms of understanding the lymph node basin and really whether a patient should have a resection or not, with many commenting on local recurrence or burden of disease, or whether radiation therapy or systemic therapy would be adequate. I think there's enough data now showing that really axillary clearance is really unnecessary in the majority of patients. But how can we do a better job worldwide, even amongst our care team, in terms of having a uniform consensus moving forward.
Thank you, Terry. That's a very important point. I think there are two aspects with regards to axillary surgery. One, patients who are node negative, and second, who are node positive and then treated with neoadjuvant systemic therapy, which turns them into potentially node negative patients. In my view, there are lots of countries, probably low resource countries, where even in node negative patients, axillary node clearance is happening. And that's really what we need to potentially discourage very strongly, so that patients are not brought to harm or morbidity, which is completely unnecessary. In response to your question about the other group of patients who were node positives to start with and therefore have neoadjuvant chemotherapy with sterilization of the axilla, I think the evidence is now kind of becoming loud and clear that there is de-escalation, which is absolutely safe to undertake the lesser procedure. And if there is residual disease in the lesser procedure or sentinel node biopsy, then of course you can always go back and do clearance. But offering straightforward clearance to all patients is completely not necessary. And this is something which is getting more and more accepted. I agree there is still variation, and partly a lot of it is a degree of logistics or competing priorities, resources, individual preferences. And I think guidance, national guidances, the guidelines and policies will help to uniform these procedures, because I saw similar things happening for Oncoplastic about 10-15 years ago. So hopefully in the next coming years, we will be able to make that change, which will be desirable change.
Okay, I think we must conclude now. It's 1 hour. And I thank Professor Pankaj Roy, Professor Sarantou, and of course, all the participants. And before to say goodbye, I like to remind you the next webinars in 2023, always Friday at 12 p.m. UK time, 17 March, 16 June, 29 September, and 24 November, with exciting subjects about screening program in Turkey with Veit Osman and Hans Junkerman, about tailored oncology for all breast cancer patients with Sabine Sieslin and Helena Earl, about cost-benefit analysis of new cancer medicine with Namaka Lasebikan, and about the new global Concord survival data for breast cancer with Claudia Alemani, Robin Jabrov, and Nirmala Bhopati. So thank you all, and see you in March 23. Thank you. Bye.